A very good day to all of you. This is our lecture on projection geometry, image characteristics, and faulty radiographs. The learning outcomes would be to define density, contrast, sharpness, and resolution, and explain the factors that affect the radiographic image. Next, describe two methods of object localization. This is a new concept that I will be teaching you in this chapter. And identify and describe the causes of faulty radiographs. First of all, you must understand that a radiograph is a two-dimensional image of a three-dimensional object. That's why the radiograph shows you image of a three-dimensional object like this shell on a flattened surface, and hence the one thing that you need to perceive is the depth, which can be sometimes tricky and difficult to do. There are certain characteristics of an X-ray film which make up the image, and in this lecture we're specifically talking about image characteristics of a radiographic film and not of that seen in a digital radiograph. Hence, the most important characteristics that we need to discuss today are density, contrast, speed, film latitude, noise, sharpness, and resolution. So the overall image quality is a combination of all of these features. Let's first move on to density. Density is the overall degree of darkening of the exposed film. In this grid here, you can see five images of the same radiograph, and it isn't very difficult for us to identify that image B is actually the darkest of all of them, and hence image B has the overall highest degree of darkening, and hence it is the most dense image. Uh, Moving on, radiographic density is influenced by exposure and subject thickness and subject density. But when we talking about exposure, we can increase exposure to the film by increasing the current, voltage, or exposure time. When we increase all of this, more photons reach the film, and hence there is increased density of the radiographic image. Similarly, when the subject thickness increases, that means thicker the subject, more beam is attenuated, and you get a lighter image. That means, for example, if you're using adult exposure for a child, or you're using adult exposure for a jaw which doesn't have teeth, then you're going to end up getting a darker image in the area. Subject density depends on relative density of the area being imaged. For example, a metal restoration is more dense compared to enamel, which is more dense compared to dentine and cementum, uh, and denser than bone, muscle, fat, and air. That means a dense object is a better absorber and hence leads to more radio opaque or white image on your radiograph. Whereas an object which has less density is a weak absorber and lets all the X-ray photons pass through it and hence ends up appearing radiolucent or black. That's why your metal restoration gives a more whiter or radio opaque appearance, whereas air, which is around the tooth, gives radiolucent or black appearance. Moving on to contrast. Radiographic contrast is the range of densities on a radiograph. It is the difference in densities between high and dark regions. High contrast areas or high contrast images show both light and dark areas, and they have a short grayscale. Whereas low contrast images show only light gray and dark gray areas and have a long scale of contrast, long gray scale rather. So that means high contrast images show you both light and dark areas. This is what we're talking about grayscale. That means if this extreme end is black and this side is white, and in between you have all the shades of gray. So radiographic contrast is influenced by subject contrast and scattered radiation. Subject contrast depends on the thickness of the subject being radiographed, the density, the atomic number. Also, as the voltage of the X-ray beam increases, the subject contrast decreases. Is also influenced by film fog, which is caused by increased density of the film due to improper safe light or storage at high temperatures or developing at high temperatures. So again, this is very unique to film-based radiology. Scattered radiation, on the other hand, can be reduced, and this can be reduced by lowering the voltage using collimation and grids, which are already inbuilt in your intraoral X-ray machine. If you compare these two photographs over here, you will see that the image on my right side has got better contrast. And why would we say that? Is because it's got more sharp black and white areas in comparison to this image, which shows you more gray areas, and hence when you have a longer gray scale, it leads to a low contrast, so the image doesn't appear in what we perceive by our eyes as clear, and hence this image is more clearer because we're able to clearly define black and white areas and few shades of gray in between. So if you put that same principle to radiographic images, you will see that the image which on my left side, which is having more clarity, is because it has better contrast. It can show you very dark and very white areas, and that's why allows you to see this caries here very clearly and can be demarcated as radiolucent areas in comparison to the dentine, which is more gray. On the other hand, on this radiograph, since the contrast is low, everything is appearing gray, and that's why it doesn't allow you to see the caries very clearly because it blends in with the gray color of the adjacent dentine. So that's why a high contrast image is very useful in diagnostic radiology, as it shows you very dark and very light areas and fewer shades of gray. Whereas in a low contrast image can be of use only when you're diagnosing periodontal pathology, for example, the height of bone. Film fog, like we spoke about, is something which blurs the image and hence doesn't allow you to appreciate the details and cannot be used as a diagnostic image. Moving on to the next important image characteristic, which is speed. Speed is the amount of radiation required to produce an image of standard density. Faster the film, the better it is, and faster film requires lower exposure to produce a density of 1, and a slower film requires longer exposure. So these days we are using the F speed films, and in fact, films which are F speed require half the exposure time and half the radiation dose of ultra speed films or D speed films. Now, the reason why film speed is categorized as F or E depends on the size of the silver halide grains and the content of the silver in them. So, what makes F speed films faster, or why is it that an F speed film requires lesser amount of time of exposure in comparison to E speed film, is because of the presence of tabular crystals and hence more silver. So a tablet form of a crystal or a tabular crystal gives more surface area for absorption than a globular crystal which was seen in the E-speed earlier version of the films. So the speed of the film can also be increased by processing at high temperatures, but it would cause increased film fog and graininess, and your ultimate image wouldn't be as clear as you wanted it to be. The speed of the film can be lowered by processing in depleted solutions, so it's important that we always use fresh solutions in film-based radiology. Moving on to film latitude, it is the measure of range of exposures that can be recorded as distinguishable densities on a film. A film with wide latitude can display wide range of subject contrast, and hence it's useful to see both osseous structures of skull and soft tissue for facial region. And that is the reason why earlier when we were using film-based radiology for, let's say, the cephalogram here, it enables you to see both the shadow, soft tissue shadow of the nose and the lips, and also the osseous structures. But now that we've moved on to digital radiology, film latitude is less applicable as an image characteristic. Moving on to radiographic noise, it is the appearance of uneven densities of an uniformly exposed radiographic film. The main cause of noise is radiographic mottle and radiographic artifacts. Mottle is a term used for uneven densities resulting from physical structure of the film itself. Example: film graininess, which is seen when film is processed in high temperatures, or artifacts which are caused by defects during handling. That means they are errors in film handling. For example, fingerprints, bends, or processing errors or scratch marks, which can all contribute to radiographic noise. The last image characteristic is sharpness and resolution. They are often together contribute to what we call as clarity of the image. Sharpness is the ability to define edge precisely, which means that if your ultimate radiographic image is allowing us to see the dentine and enamel junction very clearly, or able to appreciate a thin trabecular pattern or thin trabecular plate, it indicates that the image quality is quite sharp. Resolution or resolving power is the ability of a radiograph to record separate structures that are close together. How well a radiograph is able to reveal small objects that are close together means resolution. Now these are independent. Resolution and sharpness are independent of interdependent, sorry, and can together determine the clarity of image. The resolution is measured as the highest number of line pairs per millimeter that can be distinguished. For example, line pair means that a line, a white line, and the space in between it is called as a pair. So a line and a pair, if for example, in a panoramic film, five lines and pairs can be distinguished in a space of 1 millimeter by the naked eye. Whereas an IOPA film has better resolution. It allows the eyes to see 20 line pairs per millimeter. The clinical application of this would mean that if in case we were to look at details, for example, the presence of a fracture line in a tooth, or the canal morphology, or if you're looking at finer details of trabecular pattern, it is better to use a IOPA film as a diagnostic tool rather than a panoramic, which gives you lesser resolution and lesser detail. So that's why a intraoral radiograph is a better diagnostic aid in for visualizing caries or periapical pathology or even tooth fractures, whereas a panoramic radiograph would be a better modality for image modality for viewing or screening or when you're looking at larger areas. So this is just a diagram to show you, or a photograph to show you what we mean by resolution and sharpness. So we can easily understand that this particular circular area has got more clarity in comparison to other areas which are less sharp and have less resolution. Also seen in these photographs here, the bird in the final image here has high contrast and high resolution. That's why you are able to define it very clearly and see it very clearly. Apply the same thing to radiographs. Also, the image with high resolution and high clarity is the best useful, it has best or maximum usage in diagnostic radiology. So the methods of minimizing loss of image clarity would be to use a small effective focal spot as practical, which is again inbuilt already in your intraoral machine, and increasing the distance between focal spot and object by using a long open-ended cylinder. Now this can be done by choosing a manufacturing or device which is already having a larger cylinder. So again, this comes from the manufacturer already. And what is in your hand is to minimize the distance between the object and the film, and hence image clarity can be maintained even when using paralleling technique or bisecting angle technique if you actually maintain the small distance between the object, that is your tooth, and the film. When we're talking about size distortion or image size distortion, it is important to understand that the object or the tooth should be, as far as possible, should be parallel to the film, or the film should be parallel to the object, and the source of image energy, that is the X-ray machine, should be within the distance of 8 to 16 inches from your object, which will result in good images. Anything lesser than that or more than that would result in a size of the image being distorted. So 8 to 16 inches translates to 20 cm to 40 cm. So that means it's important to place your X-ray cone or your source of the X-ray within this distance to the patient's cheek or patient's tooth. Shape distortion, image shape distortion, it is the result of unequal magnification of different parts of the same object. Now this can happen when not all parts of the object are at the same focal spot to object distance. So positioning the film parallel to the long axis of the object and orienting the central ray perpendicular, that means 90 degrees to the object and the film, is very important to avoid any shape distortion. With this regard, it's important to introduce two terms. One is elongation and the other is foreshortening. What do we mean by the term elongation? Elongation of a radiographic image results when the central ray is perpendicular to the object but not the film. That means the X-ray that is coming from the center of your X-ray machine or cone is perpendicular to the tooth but not to the film. Foreshortening results in when the central ray is perpendicular to the film but not to the object, and hence again results in a shorter or a smaller image than what the actual size of the object is. When we're discussing foreshortening and elongation, head positioning of the patient is very important, and sometimes this is one area which is overlooked by students. So when you're taking a maxillary radiograph, this should be the head position, and the mandibular radiograph, the head position is slightly different. Head is well supported in both these cases, but in a maxillary radiograph the maxilla is parallel to the floor, whereas in a mandibular radiograph it's the mandible which is parallel to the floor and not the maxilla. So the correct position of the central ray, imagining that this is the central ray which is passing through the long axis of the tooth, it's important to understand that in a bisecting angle technique, when all of these parameters are in the exact position, only then you would get an image which is of the same size as the natural tooth. Should there be any um, errors, that means foreshortening is caused by projection of central ray from an angle that is too great, and elongation is caused by projection of a central ray from an angle that is too small, which means that, for example, a mandibular lower central incisor, let's say you're using minus 15 as the exact angulation to get a correct size of the image, and you end up using minus 25, which is an angle which is greater than what is supposed to be used, you end up with foreshortening. On the other hand, if instead of minus 15 you end up using an angle which is only minus 5, you end up getting a larger image of the tooth, which is an elongated image. So both these cases, the ultimate image or the final image becomes non-diagnostic. Similarly, in the previous slide, we were talking about vertical angulation. Now, if you were to talk about horizontal angulation and you pass the central X-ray exactly through the embrasures between the teeth, so there is no overlap, you would get a correct image of teeth without overlaps with proper horizontal angulation. But if there is an overlap, that means if your horizontal angulation is not zero and you end up giving a shift in your X-ray machine, you end up with overlaps of proximal surfaces, and this becomes a non-diagnostic image. That means it doesn't allow you to see the proximal surfaces as they're all overlapped, and you wouldn't be able to diagnose the proximal caries in this kind of a situation. That was about the image characteristics of a film based radiograph or film based radiology. And now, moving on to the other part of this topic is object localization. Now, this is a very interesting part of this chapter and is often asked as an OSCE question. An object can be localized by two techniques. One is a right angle technique, also called as cross sectional technique, in which two X-rays are taken at right angles to each other or two projections are made. In the second technique is the tube shift technique or buccal object rule, which was term was coined by Richards in 1952, also called as Clark's rule, which was coined in 1910, way before Richards has actually coined it. Essentially, the technique used is SLOB. SLOB stands for same lingual opposite buccal. This object localization is used for localizing pathosis, supernumerary teeth, fractures, and foreign bodies in the jaw with the help of radiographs. Let's speak more about this and make you understand what exactly we're talking about. If you have an impacted canine, like here in this panoramic radiograph, when you're looking at this or you're looking at this IOPAR here with this impacted canine, this image actually doesn't tell you whether the canine is located on the lingual surface or palatal surface of the lateral incisor or is located on the buccal surface. So it's important that you take another image which is exactly right angles to this angulation of the initial IOPR that you've taken. That means you take a maxillary and a maxillary cross-sectional occlusal view, and hence it helps you determine where this canine is located. But not all cases can be used. You can use the right angle technique. Some cases require a different technique, which is the buccal object rule, which states that when two different radiographs are made of a pair of objects, the image of the buccal object moves relative to the image of the lingual object in the same direction that the X-ray beam is directed. Now, what does that mean? For example, you have an object here and you have taken a radiograph. If this object were placed on the lingual surface or on the buccal surface, the resultant image would look similar. That's because radiograph is a two-dimensional image where the buccal and the lingual surfaces exactly superimpose over each other, and an object like this is very difficult to determine based on the radiograph whether was it located on the lingual aspect of the tooth or was it located on the buccal aspect of the tooth? So how do we solve this problem? This problem can be solved by shifting the X-ray machine, just like we did in the previous slide, by changing the horizontal angulation. That means you change the direction of the X-ray cone completely. Take the machine and shift it. Let's say for example here we've shifted the machine mesially. If you observe in both these images, the X-ray is coming from a more mesial direction. Why are we calling it mesial? Because we can see more of the canine here. That's why it's mesial. So if we shift the X-ray cone mesially, and your final image, the object has moved also mesially. Like for example, in the first image, the object which is placed on the lingual side is exactly at the apex of the second premolar. But in the next image, when we move the X-ray machine more mesially, this object also has moved mesially from apex of the premolar to in between both the premolars. So, same lingual. When the machine is moved mesially, the object also has moved mesially, which means that the object is located on the lingual side of the ridge. On the other hand, when the machine is moved mesially and the image of the object has moved opposite direction to where it was in the first image, it means that the object is located buccally. Same lingual, opposite buccal. I'm sure you still are blurred regarding this concept. Let me explain it to you again using some more slides. What is the horizontal shift that we're talking about? Let's look at this maxillary arch. We have taken two images here with film A and film B. When you've taken the first scout radiograph, that is a film A, you've noticed that there's an object located exactly superimposing over the mesiobuccal root of the tooth. Now, but you are not sure based on this image whether this object is located on the buccal aspect of the ridge or inside the palatal aspect of the ridge. Right. So, because this is something which you cannot see, you only imagine. So, the solution to this would be to take another X-ray, keeping the film in the same position that you had kept it previously, but just shifting the cone. So in this situation, we have shifted the cone distally. We've taken the whole X-ray machine and shifted it distally. That means we keep the same vertical angulation. If it is plus 20, we keep it at plus 20, but we shift the machine, give it a horizontal shift, and we shift it distally. So when you've shifted it distally, what has happened? You notice that this dot which was there has moved distally. Initially it was in the first image, this dot was at the apex of the mesiobuccal root, but in your second image this dot looks like it's moved closer to the palatal root because you moved your X-ray machine distally. So this is also moved distally. So same side, which means that the object is located palatally. If you've still not understood, let me make you understand using this concept. So let's imagine you're taking a radiograph of the upper maxillary arch and you get an image, resultant image, which looks like this. That means you have two objects which have superimposed each other over each other and you have no clue on which surface they lie, right? So this is how you've done the first image, right? Based on the cross section, we already know that the yellow circle is on the buccal surface of the arch and the red triangle is on the lingual surface of the arch. But when you take an IOPA using normal angulation, they end up superimposing over each other. So what do we do now? We change the horizontal angulation and give this a shift. Now it's up to us. Either we shift it mesially or we shift it distally. Now let's say we have shifted it distally. When you have taken an X-ray by shifting the whole machine distally, you notice that in your resultant image the objects have moved in different directions. The buccal object has moved to the opposite side of the X-ray machine's movement, whereas the palatal object or the lingual object has moved to the same side as the X-ray machine. Right? So this is called as same lingual opposite buccal or buccal object rule. To understand it further, we can also move the X-ray machine in the vertical direction rather than horizontal shift. Right, so let's look at this example again where you're having two objects which are superimposing over each other in the resultant image. And how do we know which object is on which side? By shifting the vertical angulation. Now, let's say we change the vertical angulation. For example, in this case, instead of giving it a minus 10, let's say we've given it a plus 10 vertical angulation. What would happen? You would see that both the objects move away from each other in the second object. So the object which has moved to the same side as your X-ray machine, that means upwards, it's moved same direction, is placed lingually, whereas the object which has moved away from your X-ray machine, the direction of the X-ray machine, is placed buccally. Same lingual opposite buccal. Let's try and understand it further with the help of real radiographs. If you notice here, this is a usual IOPA taken of any root canal treated teeth. Now we are all aware that the first maxillary premolar has two roots, and if you have done the root canal treatment, you should be able to see two obturated canals. But when you take a good radiograph, they actually superimpose over each other and don't allow you to actually see which one is a mesial canal, which one is a distal canal. So the best method to understand this is by taking a shift radiograph. So when you've taken a shift radiograph, you can see two canals here. Now how do you know which one is a mesial canal and which one is a buccal canal? It's because this red arrow mark is pointing out towards the shifted canal. So in this you understand, if you look at these two radiographs, if this was taken first and this was taken second, you understand that the second radiograph has been given a more mesial shift. Why? Is because you can see more of the canine, right? So if you've shifted it mesially and you can see two canals here, two radio opaque obturated canals, the canal which has moved towards the same side as the machine, the red arrow mark, has to be the lingual canal or the palatal canal, and the opposite side one is the buccal canal. That's what this diagram is trying to show to you, right? So when you're saying two canals which are superimposed over each other, you shift them. The one which is moved towards the X-ray machine side is the lingual canal, and the one which is away from the X-ray machine side or opposite their direction is the buccal canal. Let's do an exercise with this concept. A small little exercise where you see that this is the first image taken. This is a canine which is impacted. If you notice the tip of the cuspid, where does the tip of the cuspid lie relative to the root of the left lateral incisor? Now the tip of the cuspid in the first image is exactly superimposed over the lateral incisor and is very close to the central incisor. In the second image, you can obviously see that the X-ray machine has been moved mesially because you can see more of the other lateral incisor and canine on the other side. So if the machine has been moved mesially, what has happened to the image of the canine? The image of the canine also seems to have moved mesially. Why? Because now it's completely covering the root of the lateral incisor and it is very close to the central incisor. Also, it's covering part of the central incisor. Hence, the tip of the cuspid lies lingual to that of the lateral incisor. So that helps, that is of value when you need to make an incision. For example, the surgeon knows exactly where he needs to place the incision because now you know that the canine tip or tip of the cuspid is on the closer to the palatal aspect, and hence it's prudent to make the incision if in case you were to extract this tooth on the palatal surface. So another interesting finding is the images of the roots tilt in the same direction in which the X-ray beam is directed, and that's not obvious because you're trying to make a horizontal shift. Let's look at this radiograph. Now, if you look at the first radiograph and the second one, the important what you notice here is that in the second radiograph, you notice more of the lower border of the mandible, and hence it's easy to make out based on these two radiographs that the second radiograph has a different vertical angulation. Perhaps this is with 0 degrees vertical angulation and this must be with a minus 10. Now, the question here is root A lies on which side of root B? That means when you're looking at this radiograph here, does root A, the curvature, is it curved more towards the palatal aspect of root B or towards the buccal aspect of root B? Again, why do we need to know that? Is because if you're trying to surgically extract this tooth, then it's important for us to know where the root lies so that there is ease or we're not having surprises when the surgery is being done. So if you've increased the vertical angulation, or basically the vertical angulation, the x-ray machine has been moved down more lower, you have noticed here that the root A also has moved lower. That means root A, same lingual, is placed lingual to the root B. Here there are uh, two impacted teeth. So the question is, where do the crowns of the supernumerary teeth lie relative to the roots of the erupted teeth? If you notice here in the first image, there are two supernumerary teeth, and one of them, the second one, is actually superimposing over the root of the mesial root of the first molar, and also both of them are superimposed over the second premolar. In the second image, you can see more of the canine, and hence there is a more mesial shift in this X-ray. And you've noticed that both the crowns have actually now moved to the same direction as the X-ray machine, right? So it's not covering the root of the first molar anymore, and hence it is interesting to note that when you have moved the X-ray machine more mesially, both the crowns have moved mesially in the second image, which means that both of them lie lingual to your the tooth of interest. Now, this may sound easy in the cases that I have shown you till now, but in some cases it can be quite difficult, right? So even if you've done a shift technique, it's very difficult to realize where the crown of the canine is in this, for example, in this case, because sometimes they may lie exactly in the middle of the mesia, in the palatal and buccal ridge, which makes it difficult for us to comment upon, even if the X-ray machine has you've shifted the X-ray machine and done a buccal object rule. So in this kind of difficult cases where you've tried to locate it with so many radiographs, the only solution becomes a CBCT. Of course, CBCT can come to your rescue because this is a three-dimensional image, but the downside to it is that it involves a cost and involves a lot more radiation. But yes, you can use it when you're having difficulty in localizing your object, and you will be able to see it in three dimension a lot more clearly. Now, moving on from object localization is peripheral eggshell effect. Now, this is just a phenomenon to show you that even though the egg has uniform density of the shell in all directions, when you take a radiograph of three-dimensional object like this, which has air or fluid in the middle and in the center, and has a sclerotic rim at the margin, the sclerotic rim appears uniformly dense on the periphery, even though it is of uniform density throughout. This effect can be seen, for example, in case of a lamina dura. Even though the bone is covering the entire root uniformly, you see it as a white line at the corner of the radiograph, which in corner of the root or the end of the root, which indicates that it is the peripheral eggshell effect. Similar to that of the maxillary sinus, we know that the maxillary sinus is uniformly dense and has air in it, but when you are actually seeing it on radiograph, you see it as a thin maxillary radiopacity, even that of a cyst. This is a cyst, perhaps a dentigerous cyst, which has impacted teeth within it and is expansile, and you can see that there is a thin sclerotic rim around the at the periphery of the cyst, suggesting that this is the sclerotic margin of the cyst, and probably the cyst is containing fluid or gaseous material inside. So this is called as peripheral eggshell effect. Moving on to the last part of the chapter, which is faulty radiographs. Faulty radiographs can be of poor quality and lead to loss of diagnostic information and also loss of professional and patient time. You might end up having to repeat the radiograph if your radiograph is of poor quality. The problems with faulty radiographs can happen with film exposure as well as during development. Now, these can be light radiographs or dark radiographs. Light radiographs can be caused by processing errors such as underdevelopment, depleted or diluted or even contaminated developer, or due to excessive fixation. They can also be caused by underexposure, which is an exposure parameter, due to insufficient current or insufficient voltage or even insufficient time. That means you end up exposing a molar radiograph to incisor exposure, you will get light radiographs. This can also happen if the film packet is reversed in the mouth. You end up getting the lead side of the film being packet being exposed to radiation, and you end up getting a tire track appearance, which would give you a very light image of the actual radiograph. And if the film source distance is too high. Dark radiographs, on the other hand, can be caused by processing errors like overdevelopment, concentrated developer, inadequate time in fixer, improper safe lighting, or accidental exposure to light or expired films. Overexposure can also cause dark radiographs. That means you've used excessive current or voltage or time, and the film source distance is too short. Other processing or other errors are film fog, which is improper safe light or light leaks can cause film fogging, can happen due to overdevelopment, deteriorated films being used, or contaminated solutions. Insufficient contrast can be a problem when you're underdeveloped films or underexposed films or excessive voltage or film fog. Then you could have dark spots or lines, which can be due to fingerprints, static discharge when you actually rip up the film packet too fast before processing, excessive bending of the film, trying to place the film in the patient's oral cavity and bending it, which can lead to dark lines, which are due to crease lines, and film being contaminated with developer before processing, or yellow or brown spots, which can be due to insufficient washing, and that means insufficient fixing, contaminated or depleted solutions. Light spots, which can be due to film contaminated with fixer before processing, or contact with the container, rims of the container, which can lead to light spots on the films. Finally, blurring, which could be due to patient movement or X-ray tube movement or due to double exposure. So these are some images of faulty radiographs. In this image, you can see that there is blurring of the image. Probably the patient has moved. This image shows you brown spots or yellowish brown spots, which could be insufficient washing of the film. White spots or droplets, which could be due to film getting contaminated before developing, or water contamination sometimes. This is a light radiograph with tire track pattern caused by film packet being reversed in the oral cavity during exposure. That means you have not taken into consideration the identification dot and exposed the wrong side of the film to radiation. This is due to double exposure. You can clearly make out that there's a lot of jumbled up images over here. Then you see static discharge here. This is because of static electricity being created. And this is a light image. And this one is due to fingerprints created because unclean hands or contamination during the processing, during the phase of processing. So these are just few of the radiographs that I've included here. There are more in your textbook, or you can find them in your daily practice, in routine clinical practice as well. So that brings us to the end of this chapter. Thank you for listening. I know you might have some doubts regarding the object localization or faulty images. Please feel free to contact me. You can write in the comments below, or you could message me and we can discuss it over a Google Meet session. Thank you.